So I got like a 1 hour.
Yeah, it's all getting to my head. Cool. So today we are going to be wrapping up GI Patho. This will be the last set of material for exam 4. Tomorrow, when I see you guys online, we'll do the exam breakdown. But 4 lectures, blood and guts. Yeah.
We have a quiz tomorrow, right?
Quiz tomorrow over this stuff.
Online it says it's June, or it says it's on the 28th.
It unlocks tomorrow, but because one cohort, their class is effectively canceled because of Thanksgiving, I told them, like, you have till Sunday at midnight to do it. So I was like, hey, you guys, you have till Sunday, the 23rd at midnight to complete it. So you can do it tomorrow if you want, get it out of the way, or take your time. You choose, just offered you that window. So
Thank you.
yeah. All right. So I love that. All right. Intestinal obstruction, don't overthink this. It's just like straight up mechanical blockage. Okay. So imagine, I don't know, a giant Lego block inside your colon. It's gonna cause a blockage, yeah? Yeah. A mechanical blockage is just gonna be some sort of physical thing. It could be that the poop dried up. It could be that your patient eats hair. It could be basically anything that's physical. Now, an ileus, I'm going to scroll down because the pictures of the ileus kind of describe it a little bit better. So an ileus is basically like a lack of movement. Lack of movement through the intestines. Okay. So take, for example, this herniation right here. You guys remember how we talked about the intestines popping out of the belly button? What was your big concern with that section of this section of the colon? Nice. Okay. So big issue here. Necrosis. Okay. I'm not really going to ask you any questions on the ileus because that's more of a med search 1 thing. Really, the takeaway is just going to be this corner here. Okay. Different types of ileuses. Again, you don't need to take notes on this. It's just heads up. Sometimes the intestines can kind of fuse together, whether it be trauma, surgery, or something like that. So that's scar tissue. Now, if you think about your intestines, one is moving one direction, the other intestine is moving the other direction, right? So if I handcuff you to your best friend and tell you to run in opposite directions, what's going to happen? No movement, you're blocked. Okay, that's the idea there. Volvulus, you don't really see happening in people's daily lives. Again, you don't need to take notes on this. This is more of a oopsie from a surgery. Like if we're digging around in somebody, this can happen. Intussusception, that's something that somebody's usually born with, where the intestines slide in on themselves. That's the diameter. That's why things get clogged. Okay. All right. Peptic ulcer disease. Okay. How dare you? Peptic ulcer disease. Do yourselves a favor. Anytime you see peptic, I want you to think of pepsin. What do you guys remember about pepsin? Breaks down proteins, comes from the stomach. It starts, the activated form is pepsin, activated by HCl. Nice. So we mentioned the stomach. That's where we can find pepsin. Yes. If the pepsin goes down the GI tract, what's the next structure? Duodenum. And if it goes backwards, that's those 3 places. Again, if you ever see peptic, think pepsin. Where could pepsin be? Typically in the stomach, can go down or up. Okay. And FYI, your duodenum, this is the most common, and I'll explain why. Okay. But the issue with peptic ulcer disease is this pepsin is going to start eroding away these proteins. That's its job. It's going to cause ulcers, i.e. holes of necrosis. So where would you typically find peptic ulcers? Esophagus, stomach, duodenum, because that's one of the places where the pepsin can break. Okay. So they have these like burns via pepsin. We're gonna come back to this, but this is your stomach lining. Notice you have mucus on top. Okay, that helps protect us. Certain things erode away the mucus. If we get down and expose the muscle, what's gonna happen when pepsin gets down here in the stomach? It's gonna cause a hole, that's your ulcer. Okay. So duodenal ulcers are by far the most common. Okay, why? What does your stomach have to protect itself from pepsin? Mucus. Now, food typically goes up or down. That's why it's most common. Does the duodenum have mucus? Okay, so that's why, again, most common. Another possible reason is H. pylori. H. pylori. This is a bacteria typically found in your colon. How does this bacteria get into your duodenum then? If you eat it. How would we eat colon bacteria? Fecal, oral contamination. So what I'm getting at is the bacteria that normally lives in your colon, it's too far to crawl up the small intestines, way too far. You gotta go the other route.
A lot more people have the same thing. So many.
So with H. pylori, you don't need to write this down here. H. pylori, when it gets into your stomach, it's actually a particularly nasty bacteria because it knows how to survive in your stomach. It can survive in the acid and the pepsin. What it ends up doing, it burrows into the mucus to protect itself. So if you notice, if I burrow into the mucus, I can protect myself, but this creates a channel. So therefore the pepsin gets a straight direct shot into the muscle ulcers, okay? Fun fact, the way somebody actually described H. pylori, linked it to peptic ulcer disease. To prove his point, he chugged a glass full of this bacteria.
Nobody believes it, but he won a Nobel Prize. So.
Nobel Prize in Medicine. Also, the other one is NSAIDs. So duodenal ulcers typically caused by H. pylori or NSAIDs. Okay. The other two I'm not really going to get into here, but smoking cigarettes actually decreases mucus production. So you have less mucus, less protection. Okay. We'll talk about NSAIDs in farm, but hey, shouldn't take 15 pills of the same medicine, yeah. All right, gastric ulcers. So ulcers you know as holes. What does gastric refer to? Yeah, so gastric ulcers, you know what's going on here. So if I describe peptic ulcers or gastric peptic ulcers, you know these are holes in the stomach caused by pepsin burns. Okay. Again, typically NSAIDs and H. pylori, those are the two most common causes I need you to focus on. Esophageal, so food going backwards, not typically common, but if somebody has GERD. What was GERD all about? It's acid reflux, right? If I'm constantly having that food and that kind go back into my esophagus, burning it, that includes pepsin. Okay. So for esophageal peptic ulcers, we'll just say GERD, leave it at that. Stress ulcers. So yes, stress can give you ulcers. Are you at risk for a stress ulcer?
Sure.
Why? When you are stressed out, you produce less mucus. When you are stressed out, you are at risk, or you produce less mucus. Has anyone ever had an ulcer, like a peptic ulcer or a stress ulcer? All right. Back in the day, when I started college, I had hopes and dreams of becoming an engineer. That's an idiot. I drank 8 cups of straight black coffee every morning because I had class at 8. Come around finals, I had a peptic ulcer. The way I could describe it, imagine a lit cigarette being put out into your stomach constantly for 3 days. Why? Why did that pain never go away? If I keep splashing this area with acid, I burn it, right? But this exposes new area. So the worst part about this was I never slept for 3 days. Regardless, say I failed my finals, switched majors very quickly after that. So, not fun. As a nurse, more applicable for your stress ulcers, these are going to be patients in the ICU or burns. Those are the 2 places you need to really look out for stress ulcers because their bodies are in pretty bad shape. Okay. All right. Maldigestion, malabsorption. Okay, if we're just translating this, maldigestion, that means bad breakdown. Malabsorption, bad absorption. They usually occur together. Why? If no digestion, so I would say if no digest, there's no absorption. Okay, so carbs, we need to digest before we absorb. Proteins, we need to digest before we absorb. Lipids have one extra step. What was that one extra step? Lipids need to be emulsified, then they can be digested, then they can be absorbed. Yeah. So one thing that can cause malabsorption syndrome is pancreatic insufficiency, exactly as it sounds. Your pancreas is insufficient. Your pancreas has enzymes to break down what? Fats, everything. So if your pancreas breaks down everything and it's insufficient, kind of makes sense, right? So if we have a deficiency of pancreatic lipase, that'll affect what macro? Fats. Pancreatic amylase will affect carbs. And then not trypsin, chymotrypsin, I told you guys just zymogens. Zymogens do what? Proteins. Okay. So causes of pancreatic insufficiency, just like, hey, your pancreas is inflamed, not a big deal right now. Okay. Fat maldigestion is the larger problem. Why? If my pancreas goes down, what other organ can I rely on to break down carbs? Mouth with the salivary amylase. If my pancreas goes down, what can I rely on to break down proteins? Stomach. If my pancreas goes down, what other organ can I rely on to break down fats? There are none. Okay. So again, no other organ breaks down fat. Okay.
So that lady who had her stomach removed would not be able to eat the stick of butter. No, if she had her.
If she had pancreatitis
Yes.
with pancreatic insufficiency.
Right.
Yeah. Yeah. Mhm. So you don't break down fats. Hey, guess what? It comes out and it floats. Bloop, bloop. All right. Lactase deficiency is the clinical term. You may have heard of this as something else. Lactose intolerance. Now I'm going to pick on myself here. I am personally lactose intolerant. Try not to be. Okay. So lactose is a sugar. So picking on myself here, let's say I decide to slam a gallon of milk because I'm a sadist. What happens to lactose in my mouth? If I'm lactase deficient, this is an enzyme to break down lactose. So I have lactose in my mouth, nothing happens. What about my esophagus? Stomach?
No.
Small intestines?
No.
Large intestines? This is the problem. I take in the sugar, I have nothing to break it down. I have nothing to slow it down. So this lactose shoots through my system and ends up in my colon. Who else is living in my colon? Please do not say Buzz Lightyear. Bacteria, my gut biota. And what do bacteria like to eat? Sugar. Thus propelling my problems. So, inability to break down lactose. It basically goes straight to the bacteria in my colon, and they begin to ferment. They begin to throw a party. Bacteria like to eat sugar. They're going to start replicating, making more of themselves, making a lot of byproducts. And their little bacterial farts become my farts. And if there's too much bacteria, bacteria are made of protein. What do protein do to water? Follows it, it pulls it. So, hey, all this water is going into my colon, setting me up for
Diarrhea.
what kind of diarrhea? There's three.
The terrible.
Nice.
Yeah, the screaming on the toilet.
Excess protein. I'm going to say from increased bacteria. Okay, so be careful here. This is not secretory diarrhea. It's not that the bacteria are foreign. It's not like a parasite. These bacteria have been living inside of me already. So just heads up, osmotic diarrhea, not secretory. Okay. Now, one day, if I try hard, can I learn to be tolerant? Can I learn how to tolerate lactose? We need the enzyme. We were all born with it. Breast milk. We were all born with lactase. As soon as you get removed from the teat, no more breast milk, no more need for lactase, you start producing. If I try hard enough, I could actually learn to be tolerant. I can learn how to remake lactase. 3 months of hell does not sound worth it. Okay, so biosalt deficiency. So again, biosalt, primary ingredient in bile. What did biosalt do? Or bio? Fat emulsification. Okay, now if I have a biosalt deficiency, that means I have less fat emulsification, which means what happens to fat digestion? No digestion. What happens to absorption? No absorption. So what kind of stools do we get to look at? Bloop, bloop. Okay, so fatty stools. Why would someone have a biosalt deficiency? Where does biosalts come from? So liver disease and or some sort of obstruction. Big issue is your fat soluble vitamins. You need bile salts in order to break down your fat soluble vitamins. So if you don't have any bile salt, you don't get these vitamins. What's the consequence? This is the slide you're going to be responsible for on the exam when it comes to vitamin deficiencies. Again, I used to teach nutrition, so I'm going to kind of get into a little bit of the weeds here. This is the slide you need to study. Okay, so vitamin A, big one for you guys is going to be night blindness. Okay. Vitamin D, you need vitamin D for calcium absorption. What happens when your bones don't have vitamin D? What happens if you don't absorb calcium? You get soft bones, you're going to see rickets / osteomalacia. Or Malaysia, however you want to say it. Rickets / osteomalacia. And I'll explain the difference between that and osteoporosis. Vitamin K. Oh, that sounds familiar. What was that? It's the precursor. Precursor to prothrombin. As we take vitamin K. Take vitamin K, convert that into prothrombin. Okay. You also do get that from your diet, leafy greens. Vitamin E, for all intents and purposes, we're going to leave it as an antioxidant. Now I'm going to be throwing a giant blanket statement out here. Vitamin E is an antioxidant and helps prevent cancer. So with the rest of the slides, I'm gonna go more in depth with it, but this is what you're responsible for the exam. Okay, so the next few slides are just gonna kind of be like an FYI. All right, so vitamin A, you need vitamin A for your skin and your lining. So hey, lack of vitamin A, your linings dry up. Night blindness. So if you eat enough carrots tonight, can you learn how to see in the dark? Anyone ever try? No, you're never gonna see in the dark no matter how many carrots you eat. What I'm saying is right now, your vision in the dark right now is as good as it's gonna get. You have hit your peak. From here on out, the only thing you're gonna look forward to is less vision at night.
Great.
Sorry. Eating vitamin A helps preserve that decline so it doesn't decline as quickly. Okay. Fun fact, did you know carrots helped win World War II? So,
Do they
this
see their enemies through walls or something?
kind of
They have like radar?
ish, close. So what happened was the British SAS, they started some propaganda for their people. They're saying, hey, people, eat your carrots because at night we're going to turn off the lights. Turn off the lights because the Germans are going to bomb us. They're going to hit the lights. We need rolling blackouts. So they started getting the British people to eat a lot of carrots. And then as Nazi bombers were approaching London, they were getting shot out of the sky at night. What the hell is going on? These British pilots are seeing at night. So they, do a little spy work. They find out that Britain is quote unquote force feeding their pilots so much carrots that their skin is turning orange. That's why they can see at night. That's why they're shooting the bombers. The Nazis freak out so much they put a blockade around England. No carrots in this country. Okay. And now the Nazis start force feeding their pilots carrots. Now the problem is vitamin A is a fat soluble vitamin. Can you overdose on it? Guess what the Nazis started doing to their pilots? Causing liver failure, killing off all of their top pilots. Like, what the hell's going on? Turns out the British just invented a better radar. And the whole carrot story was a cover behind that. So, hey, eat your carrots. Nazis are bad.
Eat your carrots.
So your corneas are pretty clear, yes? You need vitamin A to keep it clear. Lack of vitamin A causes dryness. So xerophthalmia, this little foaminess happens, okay? If you see this in a patient, if you see like little foam bubbles or drying of the corneas, vitamin A is the way to go. Once the eye dries out to this point here, blindness is permanent, okay? So eat your damn carrots. Vitamin D. So we need vitamin D. So we say vitamin D allows bones to absorb calcium. Okay. Vitamin D allows bones to absorb calcium. So rickets and osteomalacia, these are soft bones. With rickets, that happens as in childhood. So I'm going to say kids. Osteomalacia or malacia is adults. Okay. So you go to the store, you get milk. Doesn't matter if it's cow milk, almond milk, oat milk, goat milk, coconut milk, soy milk, almond milk, pea milk. There's a lot of options out there. Rice milk, all of them by federal law have to be fortified with vitamin D, or else you're getting all this calcium and it's not going into your bones. Okay, so think about kids developing. When babies are born, are their bones solidified?
No.
Thank God, no. If you had a fully formed skeleton at birth, call your mother and apologize right now. Okay. Kids have soft bones. Kids without vitamin D grow up to have rickets. Okay. So looking at rickets, these bones are very soft, and therefore they can take on this bowing. Now, what's a great source of vitamin D? Colorado. Sunlight. When UV radiation hits your skin, what happens is it hits the cholesterol in your skin, converting that into basically the vitamin D precursor, goes to your kidneys, gets activated as vitamin D. So sunlight is a great way to make vitamin D and lower your cholesterol. Sounds great. Not all the places get 300 days of sunshine, right? So soft bones like this, why would we see bowing in the legs, not the arms? Pressure, weight, body support, absolutely. So question, this kid has soft bones, can I just give them vitamin D and calcium at this point? Would this fix their legs? If I give them vitamin D and calcium, what's gonna happen to their bones? It's gonna solidify like that. So with rickets, generally we want to put them in braces before we calcify their bones. If their bones have already calcified, this is pretty gnar. We basically take a chop saw and we cut the leg in 2 sections. Then we insert pins to straighten out the leg and wait for the bone to grow in between the gaps.
I'll take the
Osteomalacia, osteomalacia. So this is in adults. So adults with soft bones. Okay. Now let's think about this. Right now, you guys are all adults. If you stop eating vitamin D, you stop taking in calcium, what would happen to your bones? They wouldn't soften.
Would they get thinner?
They get thinner. That's osteoporosis. They get thinner. They get osteoporosis. You wouldn't all of a sudden have soft bones. So how does an adult have soft bones? It's basically unresolved rickets. They had soft bones as kids, never allowed them to harden, and now they're adults. Okay. So that's the difference between osteomalacia and osteoporosis. You are at risk for osteoporosis. Somebody with rickets is at risk for osteomalacia. Okay. Anybody identify what that bone was?
Femur.
It was the femur. Can you imagine if that was your femur? Here's the hip joint. There's a curve. There's a spiral. Okay. I'll tell you, this leg was never weight bearing, which means that this person was born, lived, and died in the same bed. Okay. Vitamin E, again, is the antioxidant. Just roughly saying it helps prevent cancer. Okay, so vitamin E is great, helps prevent cancer. Fun fact, you also use vitamin E for your nerves in terms of myelination. So again, you don't need to write this down, but if you're interested in working with patients with neural cord injuries or nerve injuries, giving them vitamin E can actually help increase the rate of myelination, therefore increase the rate of nerve growth. All right, so I know this doesn't break. Well, it's just because I want to break it up where we kind of go through material and then eating disorders in the middle and then more material at the end. You guys cool if we roll a little bit more? Gastritis, don't worry about it. Inflammation in your stomach, don't worry about it. Okay. So now we're talking about some inflammatory disorders, particularly of the bowel. So i.e. the colon, and these disorders are of unknown origin. So they're idiopathic, okay? These are possible causes that I do not care about. Don't worry about these 4. Okay? Again, we do not know, they are idiopathic. The 2 disorders we're talking about, ulcerative colitis and Crohn's. Okay? They typically happen at the colon, so in the large intestines. That's what we were talking about with the bowel. We're going to talk about them, but you're going to see that it can be elsewhere. So starting with ulcerative colitis, chronic inflammation. Typically it starts at the sigmoid colon and the rectum. Okay, so ulcerative colitis, inflammation of unknown origin, we don't know why it's inflamed, of the butthole and the sigmoid colon. Okay, the problem is that it travels backwards. So patient has ulcerative colitis with significant inflammation of the rectum, sigmoid colon. What's next? the descending colon, transverse, ascending. This can technically go from butthole all the way to mouth. Okay,
I thought only parentheses occur anywhere in the GI system.
we're gonna get to that too, but technically this one could cause inflammation all the way up. Very rarely does it because people kind of die before then.
I was gonna say, Lindsay told us that from the only in the core.
Who?
Lindsay, when she taught us that, I was like, that's good.
Sorry.
That's okay.
This one's the answer.
I'm gonna say consecutive. How do you spell consecutive?
C-O-N-S-C, I mean, S-E. And what are we?
Consecutive?
Never mind, I don't know. Yeah, that looks right.
Okay. So it travels backwards, but it goes through each organ consecutively. Okay, it travels through each organ consecutively. Again, I do want to just reemphasize to help kind of like hopefully meld things over. It typically happens in the colon. Okay, it doesn't have to progress all the way, but it can. Now, it does lead to significant increased risks of colon cancer, and we're going to talk about why. Okay. So this is somebody's colon with ulcerative colitis. As a nurse assessing this, what do you observe? What do you see?
Necrosis. Bleeding.
I would see inflammation, agree, redness, bumps.
Blood.
Those little pockets right there, those are bloody pockets. Now, let's think about this. Your colon is bleeding. What kind of material does your colon move? Poop. Every time you poop, you're rubbing fecal matter into these open blood wounds. You're looking at increased rates of infection with inflammation. That's your colon cancer right there. Okay, so let me say due to infection and trauma. Okay, so treatment then. Is this part of the colon going to be able to absorb anything? There's only really a risk for infection, so what we do? That's what we did here. We're going to remove it, okay? If we remove it, hopefully that prevents any further progression. They might need a colonoscopy bag, may not. All right, Crohn's disease. So again, both of them are idiopathic inflammatory disorders. And with Crohn's disease, anywhere between mouth and butthole, but typically in the colon. Okay. Now, there are two kind of signature symptoms. Signature symptoms. Skip lesions and cobblestoning effect. Skip lesions and cobblestoning effect. I promise to kind of define this as well. So right here, what's the big difference between this colon and the last colon? Yeah, it's got those nodules, those bumps. Those are your cobblestones. Sorry, it's a little washed out, guys. But you can kind of see those little red bubbles. Those are cobblestones. So you show the camera up somebody's bum, you see cobblestones. Is it Crohn's or ulcerative colitis? Instant, done. What if you don't see cobblestones? What if you just see, like kind of in this section here, there's no cobblestone here. Okay, this is where skip lesions come into effect. Skip lesions. This is where we have alternating areas of inflammation, or I'm going to say inflamed, alternating areas of inflammation and unaffected tissue. Okay, skip lesions, alternating areas of inflammation and unaffected tissue. Take a look here, rectum, sigmoid, any inflammation? Now, of the ascending, we have inflammation, unaffected tissue, inflammation. With ulcerative colitis, remember, it travels backwards consecutively. So basically, if you're looking at somebody's ascending, descending colon or anything like that, you see that there's unaffected tissue, that's Crohn's. Okay, so in terms of a question for you, let's say a patient has inflamed sigmoid, transverse, and ascending. What would that be? Crohn's or ulcerative colitis? Sigmoid, transverse, ascending. Which one did we skip? Descending. So if we skip the descending, you instantly know it is Crohn's. I did not spell that right. Yep. Okay, another question. What if patient has inflamed ascending, transverse, descending, and sigmoid? Oh. Sigmoid. Okay. I didn't put it in any particular order.
But the right. Sure.
That's one part of it. Or it could be both. Trick question. It could be ulcerative colitis or Crohn's. Why? Ulcerative colitis, we mentioned, is consecutive, continuous. Yes? Ascending, transverse, descending, and sigmoid. Basically, this entire person's colon is inflamed. Why could it still be Crohn's? Did we take a look at the ileum? Maybe the ileum's intact. Maybe the jejunum's inflamed. We don't know. It just depends on how far we put that camera up there. That's why it's like Crohn's. It could have skip lesions, but it might not. Okay, that's why it's both technically here. How would you discern if it's Crohn's or ulcerative colitis at this point? Or yeah, you just put a camera up there. What are you looking for?
Healthy.
Cobblestones. When you look for cobblestones, you see cobblestones, boom, you instantly know it's no cobblestones.
It's also.
Ulcerative colitis. Okay. So if you see skip lesions, you instantly know it's Crohn's. If it's continuous, it could still be both. You need to look for cobblestones. Make sure you're reading the question carefully. I'm saying yes, there's cobblestones, or there's no cobblestones. Okay. All right. Diverticula or diverticular diseases of the colon. So other kind of issues of the colon. A diverticula. This is when you have a little pouch in your colon. Bless you. Little pouch. So this is almost like varicose veins, almost like an aneurysm. What caused an aneurysm? What caused varicose veins? What would cause something to distend? Pressure, usually due to increase in pressure. We'll talk a little bit about that. So when someone has too much pressure in their colon, this can cause a little outpouching. That's a diverticula. Diverticulosis, a condition of diverticula. This person has multiple outpouches in their colon. Diverticulitis, what is inflamed? The little outpouches, yes. Therefore, I'm just putting a little red right here to show this one's inflamed. Okay, so the way to kind of look at this, diverticula leads to diverticulosis, which leads to diverticulitis. Now, diverticulitis, this little area is inflamed. Why? Poop travels through your colon, yes? Sometimes a little bit of poop gets left behind. The bacteria start having a field day. They start replicating. Nothing's killing them. Nothing's moving them along. That's what causes the inflammation here. Okay, there's a better picture coming up, I promise. Going back to the cause. What's something that increases pressure in your colon? Constipation, for sure. It's something that you never do on the first date. Or I should, it's usually what you do on the first date. Maybe by the 7th date, you let it go.
Oh.
Holding in your farts will cause out pouches in your colon. So, you hold in your farts, guess what happens? The older you get, the more farts you hold in, diverticulosis. Now, what's the problem? A little bit of poop in here. The bacteria get crazy, they start stretching out the walls, and what happens? It's inflamed, and what happens when the bacteria keep replicating? This could rupture, this could pop. Does anybody like the idea of an exploding colon?
No.
So for colon health, for science, for reducing cancer, let her rip. Okay? Please do. Okay, if you care about your colon, you care about reducing your risk for colon cancer, you will let it go. Okay, this is 2021. The world needs to hear your roar. But legitimately, when poop is passing through here and a little bit of poop gets in there, the bacteria aren't getting cleaned out. That's why they have a safe haven. That's why they replicate, stretching the tissue, causing this inflammation, leading to this rupture. Now, let's just say you got a lot of first dates you need to impress and you don't listen to me. What happens as soon as this diverticulitis ruptures? If this thing, let's just think about if your colon explodes.
You have fecal matter inside your throat.
This has poop. It's going to explode into your abdomen. You have poop in your abdomen leading to sepsis. So, sepsis, colon cancer, those are enough reasons not to hold your fart. Okay. All right, other things that can explode, your appendix, appendicitis. So inflammation of that appendix. Remember that little finger thing hanging off the cecum? Again, we keep our appendix filled with what?
Bacteria.
Backup copies of that gut biota. Okay, to help reseed our gut, to help us keep clotting our blood, XYZ. If it gets blocked, again, just like the diverticula, the bacteria start throwing a party, they start replicating, stretching out that appendix, leads to inflammation. Symptoms include right lower quadrant pain with rebound tenderness. You guys learned about this, right? A little bit of recap, because I know your guys' exam is this week. What are tests that you can do to see if a patient has appendicitis? Lumbar. You can feel the opposite side, so is that the lumbar?
Yeah, where you put pressure on the left side, if there's pain on the right side.
Okay, that's lumbar.
I didn't do well on the last exam, so you don't have to take my word. I might be wrong.
The hard part for me, like the reason why I'm bringing this up, the hard for me is I mix up Murphy's and McBurney's.
Yeah,
McBurney's
is
point is just that spot.
McBurney's is a specific location, so pain at McBurney's. Also, from now on, that's forever what I call hot and spicy's from McDonald's. So pain at McBurney's point. You can also do the iliopsoas test. Okay, positive iliopsoas test. Murphy's is used for assessing what?
I can't say the word.
Cholecystitis,
Yeah, that one.
gallstones.
It has to do with the gallbladder.
So just be careful. Murphy's, McBurney's, two different things. Yes. So right lower quadrant pain, cool, rebound tenderness. What's rebound tenderness? How would you describe that? It hurts to push it, hurts more to let go of that pressure. Awesome. I'm not gonna ask that question because I think it's confusing. Generally, these are two good ideas here, okay? But just heads up. What if you had a diverticula right here? It could, you would still have the same symptoms. You'd still have rebound tenderness in the right lower quadrant. Okay, so just heads up about that. I would not call these signature symptoms. Okay. All right, celiac disease. We're gonna keep this one really kind of brief here. Celiac is an issue with gluten, and gluten is a protein. Oh dear God. Sorry, I lived in Boulder County for a while. Okay, gluten is a protein. Carbs are not the devil. Carbs are delicious. Okay. People with celiac disease, they eat gluten. This causes their body to turn in and attack themselves. Okay, does anybody remember what celiac disease was for hypersensitivity?
It's not autoimmune.
It is kind of autoimmune, but it's delayed because there's no symptoms in childhood.
Is it type 3?
Type 4.
This is a type 4 hypersensitivity. So with gluten, okay, people with celiac disease, I genuinely feel bad for them, but people who self-diagnose themselves with celiac disease, I have no tolerance for. Y'all, like, I've heard it. Like, I have celiac disease. I'm gonna go eat sushi, and that's fine. And they start pouring soy sauce on there. I have celiac disease. I can only drink beer. All right. So, other than just like bitching about people's lifestyles, how this applies to you as a nurse? If you're working with a patient with celiac disease, of course, you need to watch their diet. Make sure that they're not ingesting gluten in the hospital. But you also need to check their medications. Gluten is a very, very common stabilizing agent. Take, for example, I forget which kind, sorry, this is my Y chromosome, but there is a birth control, an oral contraceptive that uses gluten as a stabilizing agent. You could, if you give someone their birth control, you might trigger their celiac disease, making your life so much harder. So be careful in the hospital. Just an FYI, definitely check their diet, but check their medications for gluten as well. Okay.
Okay, so it's yes.
All right. Obesity. So obesity, you don't need to know these ranges, not for me, I'm just underlining it, okay? So BMI greater than 30, you'll probably need to know the BMI scale for health assessment, but not for me. What causes obesity? Who knows? It could be life, could be genes. But what I want to talk about is BMI. As nurses, you're going to see a lot of people, and you're going to see their BMI. Somebody comes in with a 30.86. Technically, they are obese. He's on his way. He's on his way to becoming known as the mouse. Yes. Or the boulder. Okay.
You know he claims to be natural.
Does he? Well, I know he, like, wherever he goes, he has an entire semi that follows him. Yeah, that I mean.
No, it's the company I used to work for. We sold stuff with that. So
Oh.
it's like, it's legit.
Shit.
Yeah.
Yeah.
Did you hear about when he ripped his own gate off of his
Colin is.
like house? Like his driveway was gated and he ripped it off.
I mean, the gate probably deserved it.
He said the power was out there. He broke it. He just ripped it off. That's one way.
All right. So what I'm getting at here, FYI, for you guys as nurses, you see somebody's BMI, don't judge them immediately. Take, for example, GPA. You want people looking at your GPA and just instantly drawing conclusions?
No.
That's terrible. Okay, like, just because people, like, BMI is a nice, quick, easy calculation, but it does not define everybody, right? Next example, anybody Game of Thrones fans?
Yes.
Baby Bjorn, smallest of 3 brothers. I'm not kidding, he's the smallest of the 3. Okay, he's known as the Mountain. 403 pounds at 6'9", 42. Dude, oh my God. He has actually a hard water, like not hard water, a seltzer commercial. It's called Bubbles. And it's like in a dumbbell shaped bottle. It's just so cute.
Do you know he's also a DJ?
Baby Bjorn, you do it, buddy.
He makes house music.
Oh
It's
my
hilarious.
Here's-
Yeah, he makes house music. Like you're in the club and he's your DJ. I run. How about you?
You guys see one peg? It's the size of her face. Okay.
His chest must be bigger than her face.
Yes, the guy is
You know, I might be
monstrous.
thinking of Hodor. I think Hodor makes house music. One of them does. It's still really weird.
I think it's Hodor, because my whole class, we went to that concert.
Okay, is it Hodor? Okay, sorry. I mean, he's still a big dude.
Yeah.
So, okay.
All right, so obesity here in the US, for those of you, who are my transplants, by the way? Who are my transplants? Okay, got a few transplants. Colorado natives, this is more kind of applies to you guys. In Colorado, between us and I believe Washington, we compete for the 2 lowest rates of obesity in the entire US, which is awesome. What I'm getting at is be careful when you guys go out there into the field. Understand what you see around you is not representative of the entire US. Okay, when you start working with populations, obesity is so much more higher in other places. Not knocking on the South. I love the South, love Southern cooking. Food is part of their culture. That's one of the differences. Okay. So, but what I'm saying is don't get used to this as your normal because what you guys see around you, not normal. Okay. All right. Why are dudes more likely to develop beer bellies than women? And no, not because dudes drink more beer.
Wherever they carry most of their fat.
Exactly. Women typically have more subcutaneous fat. Men typically have more visceral fat. So subcutaneous fat, this is all throughout the body. Visceral fat, exactly as it sounds, it's in the viscera. Okay. Visceral fat increases risk for coronary artery disease and type 2 diabetes mellitus. Okay. So who is more at risk for heart disease? Who's more at risk for diabetes? Men, according to your insurance companies. Okay. So, yeah, that's why dudes develop beer bellies. Dead bod. Okay, so this is just to help you visualize. You don't need to memorize this. Dudes, center, women, dispersed throughout the body. I have no idea. I think maybe it's just like how women pick up their young. So it's like, I don't know.
That's okay.
I have seen a few old videos.
That explains a lot now. That is.
It's just.
All right, so we're gonna take a break here. We are gonna jump into eating disorders the next section. So as a heads up, you guys know it's pretty comical, pretty lighthearted. My tone is going to shift dramatically, just because this is really important. And I want to pay it the right respect it deserves. Okay. So break, let's say 45, we pick back up again. Yeah, so heads up, pretty serious. This is the second part of class. Okay.
I'll let you get myself in the head. Make jokes. Got it. Sorry. I will arrange myself.
Everyone deals with it.
Oh, wow. Okay, I need to start speaking.
What?
Yeah, like, right, I'm sorry. Like, no, it's good, like, it's funny. And they're like, it's not funny.
I'm crazy. And read everything.
Yeah. Just- And then even outside. Yeah, I love.
And so great people. See that from Scotland. You probably got it, like.
Yeah.
Yeah, I was gonna go back to those, but yeah. Are you doing, so you're going to Mason for this year? Do you snowboard? I ski.
Yeah.
No. School, I don't feel like I have time. Yeah. I did. I'm like, I had to go. Yeah, that's like my safe haven in the winter, so.
Yeah, it's so fun.
Even if I go a few times, I got, just Keystone and Breckenridge, it was like $400. So even if I went 4 times.
Yeah.
Not even 3 times, we'll pay it off, so. Exactly. So I'm just gonna try to go during breaks and do it that way. and see.
I guess today's the last day to buy a snack class
Mhm.
at $800.
One, yeah.
I'm like.
Yeah, so you should stay with everything. All right, so a little bit more of a kind of heavier shift here, talking about eating disorders, because this kind of gets into mental health, and that's one of my personal things. Eating disorders caused by a variety of different things, but I'm gonna get right to it. Okay, there's going to be an exam question based right off of this here. I'm going to just flat out tell you what it is, and then we'll explain it, okay? Eating disorders stem from feeling a lack of control. Eating disorders stem from a feeling that they have a lack of control. Okay, now this is not to be confused with self-control. Anybody with eating disorders, they have the utmost discipline. Okay, this is a lack of control over their own lives. Let me kind of explain. So let's think about eating disorders. When do they typically start manifesting for a person? High school, teenage, puberty, like that kind of age. Why? Let's go back to high school. Think about like junior, senior year-ish. Do you guys remember how stressful that was?
Yes.
Okay, finding a prom date. What about your SATs, ACTs? Okay, if you don't get a good score, you don't get into a good school, you don't get a good future. Are you going to be able to go to university or college after high school? Can your family afford that? Do you have to work? Do you have to take care of family? What if your friends are moving away, going to a different college? Do you play sports? There's so many different things tugging at a person that there's almost like there's no feeling of control. Okay, it is in human nature. You guys are all here. You guys are all type A's. You know how it is. We need to feel like we're in control of something. If we don't feel like we have control, that's how these things can manifest, as a way to control the craziness in our mess. Okay. So straight up, that's going to be an exam question. Heads up. Okay. All right. So starting with anorexia nervosa. Okay. So this is when we add nervosa, there's that mental disorder where this is a person is choosing not to eat. Okay. Kind of telltale symptoms here. We're going to see a low BMI. Makes sense. Okay. When it comes to eating disorders, though, nobody wears this with a badge of pride. Nobody's going to go around boasting that they haven't eaten in X number of days. Okay. We understand that it's not exactly regaled about. Okay. So if somebody has anorexia nervosa, how would they hide it? Baggy clothes, absolutely. Another thing that we're also going to see, so let me say like symptoms. We're going to see something called lanugo. These are fine little white hairs. You'll see a picture of that coming up here. Babies and elderly people typically grow these hairs. Fine little white hairs for temperature control. You might have some left on the rim of your ear. It's that peach fuzz. Okay. This is another exam question. Anorexia nervosa is the most fatal psychological disorder. That means more people die of anorexia nervosa than depression, than suicidal tendencies, than bipolar, than XYZ. Why? Because anorexia nervosa can lead to those things. Okay. The problem is it can lead to starvation-induced cardiac failure. This is what we call refeeding syndrome. Okay. So take, for example, somebody has chosen not to eat for about a week. They haven't ate any kind of solid food. If we were to force feed this person solid food, that food goes into their GI tract. Their GI tract hasn't worked in a week. It's going to pull water out of the blood to dilute, trying to make this food easier to process. That means I'm going to pull all of this water out of my blood. What happens to the electrolytes in my blood if I pull all the water out? Do the electrolyte concentrations go up or down? Becomes more concentrated. So refeeding syndrome, we see an increase in blood electrolyte concentration. Now, think back to your electrolytes. Which one are you most worried about?
Potassium.
That's why we see cardiac failure. So, the problem is this person's not eating. You force feed them food, you're going to kill them. Okay. I'm going to tell you right now, the reason why this is kind of so personal to me is because I've had so many students with eating disorders, right? If somebody's not eating and your knee-jerk reaction is just eat something, you need to broaden your scope. You should really reconsider being a nurse if that's your knee-jerk response. Okay. These disorders are people screaming for help. And if you're not hearing this, you're not hearing their cries for help, this is probably not the career for you. Okay. So again, probably the worst thing you can do with somebody with an eating disorder is just say, eat something. They know what's going on. They're not stupid. Okay. There's a reason why. So intense fear of gaining weight kind of drives this. It could be friend groups. Can we control what other people think about us? Can we control what our friends think about us? You guys see how this idea of a lack of control kind of creates these feelings? If I can't control how people think about me, if I can't control that, but I can control the food I eat, I can inadvertently influence that. It's all about feeling in control. Okay. And yes, we're bombarded from every bloody source. Media plays a role, unrealistic beauty standards. Anybody ever see Kim Possible when they were younger? Badass show. Badass show. High school girls saving the world, naked mole rat. Boyfriend, somewhat incompetent. He's sweet. And no means is this show being sexualized at all. Kids love this show. I love this show. Anybody ever notice how her wrists are the same diameter as her waist? Again, I'm not saying that that was the message that they were trying to sell, but kids see this, and we don't know how they're going to take that. Okay. Affects dudes as well. Dudes are a little bit different. The idea of machismo can't be too big, can't be too small. Ryan Reynolds, prior to Deadpool, a little bit smaller, but he's pretty successful, yeah. I grew up on comic books, 80s, 90s, for whatever reason, big muscles was the idea. Like your quads should never look like that. Professional bodybuilders look like that once a competition, that's it. Okay. So, question. We have patient A and patient B. Which one is suffering from starvation and which one's suffering from anorexia nervosa? So let's start with, which patient do you guys think is suffering from anorexia nervosa? A, B. B. Trick question. Why do I bring this up? It is so ingrained into us to think eating disorders are a female-only issue. It's so ingrained into us. Like it's something that you actually have to actively think about. Okay, but eating disorders affect both males and females. Person A on the left voluntarily chose to not eat. That's anorexia nervosa. Patient B was part of a social experiment in Michigan where volunteers volunteered not to eat. Okay, so just, hey, as nurses, differences, men, females, okay? This is that lunago I was talking about, this fine white hair growth, okay? You're gonna see this kind of grow throughout the rest of the body there. You might see psoriasis, especially here in Colorado, dry skin. Don't need to take notes on this bit here, but you know, it could just be that they don't use lotion. All right, next eating disorder is bulimia nervosa. So with bulimia nervosa, it's this cycle. You find it as the cycle of binging and purging. Binging and purging, okay? So let me kind of explain my day to you. I wake up 5:15 in the morning, walk my dog, get on the bus, hopefully by 6:15, get my ass here, just before 7, start prepping for lecture, see you guys, then I have another class, and then I have another class, and then I finally get my ass home at 8. So if you're keeping track, that's a 13-hour day. At no point do I have any time to eat. So what do you think happens when I go home tonight? I binge. Like, this is completely true. I completely binge. I shouldn't. Okay. Why? I have no control over my schedule today. If I was smart, I would say like, hey, y'all, let's all sit in one classroom. I'll lecture for 3 hours instead of 9. But I have no control over that. I finally get home. I finally get 5 minutes to myself. I haven't eaten all day and all I had is 4 cups of coffee. That's that binge. You see again how this idea of control. Okay. Now with bulimia nervosa, I binge. So actually, just pick on myself here. I binge. When am I going to binge on? High foods high in fat, high in sugar. I'm not binging on carrots. Yeah. When I take in a lot of fat and I take in a lot of sugar, that actually triggers the rewards response or reward pathway in my brain, can actually create feelings of euphoria, feeling high. I feel good. I don't feel anything anymore. Great. But then that feeling wears off. What feelings are left after that binge? Shame, regret, sadness, anger, depression. That drives the purging. Okay. So understand that these disorders can be combined. Technically, by these definitions, I'm anorexic. I have anorexia nervosa throughout the day. I come home, I experience bulimia nervosa, right? So it could be that patients experience multiple eating disorders in a combined fashion. Okay. With purging with bulimia nervosa, people usually think of self-induced vomiting, but there's other ways to purge as well. You can see excessive exercise. So we're talking about somebody who's working out 4 hours a day. And we can also see laxative abuse. Okay. Again, it's all about needing to feel some sort of control. Okay. So one thing you might see is called Russell signs. You might not really see these anymore because kids are getting smarter. Russell signs, you're going to see calluses on kind of the backs of the knuckles. What would cause those calluses? Absolutely. So if I'm using my fingers to induce this purging, my teeth are hitting the back of my fingers, but also I'm purging out stomach acid. Okay. Now you may or may not see this because kids nowadays, they're not using their fingers anymore. Pens, toothbrushes, etc. Okay. Now you might see some dental erosion, some dental damage. Okay, you can see this person's teeth are very eroded, yes? Do you guys see any signs of dental damage in this person's teeth? Okay, if somebody has bulimia nervosa, where do the teeth begin to erode first? Correct. Your dentist knows everything about you. Okay. So if you see chipped or eroded teeth, what does this tell you about this person's bulimia nervosa? It's been going on for a while. Absolutely. Especially like if it's kind of like smooth here. If it's full on chipped, it might have been more traumatized there. But that might indicate that they're using an object. But usually, if you're actually seeing the fronts of the teeth be damaged, it's been a habit. Okay. Okay, so assuming that we are not vomiting, maybe instead we're using laxatives. Okay, certain laxatives work differently. This one in particular causes you to secrete magnesium. Magnesium is a heavy metal. Now, if your colon is completely lined with magnesium, what do you think is going to happen to that tissue? It's going to start necrosing. So someone who's abusing laxatives 3, 4, 5 years would never know that their colon is necrosing. If someone's colon necroses, what do we have to do? You have to cut it out. We're gonna give them colonoscopy, colonostomy. So we're thinking about body image issues now, we're gonna be off the chain. Okay. So one thing that these two share is called body dysmorphia. So this is part of the conversation that I want us to have. So either anorexia nervosa, binge eating, or bulimia nervosa can create body dysmorphia. Body dysmorphia is where a person looks a certain way, they look at themselves in the mirror, they don't see themselves anymore the way you see. Basically, if I look into the mirror and I say like, oh, I'm too fat, and I've been saying this for weeks, months, years, multiple times a day, my brain rewires to match my description of reality. That means when I look in the mirror, I physically see what I want to see, not what you see. So you get a patient who's very thin, you're like, they might see themselves as being bloated. Okay. So working with eating disorders, the biggest thing you guys can do is express patience. They might not open up tomorrow, 2 months from now, but being patient. Okay. So let's pull in a little bit of health assessment-ish. How do you start that conversation? You have an adolescent patient, you're about to walk into the room to do your assessment. What are you going to ask them? What are you going to say? How are you going to introduce yourself? Wash your hands. Yeah, treat them like normal. So how would you start that conversation? How would you introduce yourself? It's a hard part of health assessment. She didn't teach you that, did she? What are you going to do? What's the first question you want to ask? Think about the causes. Going back to eating disorders. What's the cause of most eating disorders? A lack of control. So what can we ask? Yeah, don't even like bring it up about the appointment. Like, I see you're here to talk about eating disorders. Like, no, you bring that up, they're instantly gonna put up a wall. Instead, ask, hey, what's going on? If I ask, hey, what's going on? Who did I instantly give control to? What are they missing? This helps let them lead that conversation. Again, we don't have to talk about it if they don't want to. Okay. But as soon as you start telling them what they should do, walls go up. They have everybody else in their life telling them what they should do. You tell them what to do, you get lumped in with that. That kind of makes sense. Let them guide their treatment. Let them open up. Let them have control. That's the biggest thing. Okay. Again, we can see this with sexual assault victims as well. They had control ripped out of them. Okay. It makes the brain works in such weird ways. Ultimately, at the end of the day, we're trying to give them back control of their lives. Okay. All right. Questions about eating disorders or things like that? Like, it's a tough conversation. Okay. But I implore you guys, just act with empathy, act with sympathy, right? You guys are getting into this field generally because you want to help people, yes? So give them a chance to also help themselves. Malnutrition and starvation kind of go with this here. So malnutrition, exactly as it sounds, bad nutrition. So starvation, decreased caloric intake leading to weight loss, makes kind of sense, ties in with anorexia nervosa. When we start starving, there's the short term, long term. We're going to talk more about this here. Marasmus. Marasmus is severe, while kwashiorkor is mild. Now we're going to talk about them, but understand both of these disorders are actually pretty severe. Both of these disorders are life-threatening. The only reason why I say kwashiorkor is mild is because in comparison to marasmus, kwashiorkor is mild. Okay. And you guys remember cachexia? What does cachexia mean? Yeah. Wasting of, I'm going to say tissue. So assume that I am living in a very impoverished country I only have grains, rice to kind of sustain my diet. Okay. I get pregnant, I give birth to my first child. I'm going to start breastfeeding my child. I'm eating grains, it's fine. That child's breast milk is the sole source of nutrition. Breast milk, carbs, fats, proteins, great. I get pregnant in less than a year, give birth to a second child. I only have enough milk to feed one child. Do I feed my firstborn or my secondborn? I take the first off, I start feeding my second. Now my firstborn has no source of fat, no source of proteins. That's what leads to kwashiorkor. Okay, so that's what it's talking about, the immediate cessation of breastfeeding, i.e. a lack of protein in diet. Okay, that's what we're kind of talking about here with protein energy malnutrition, PEM. Okay, now a lack of protein is going to lead to swollen cheeks, arms, legs, i.e. edema. What is the link between protein and edema? If I have less protein, let me say less protein intake, that means I have less albumin, less pulling of the water, or less capillary oncotic. That leads to edema. Okay, so thankfully you guys have seen that before. So kwashiorkor, these kids are actually really swollen, really bloated. Okay, and it looks like they've eaten, but they actually haven't eaten in a long time. Marasmus. Basically, this is again, quote unquote, severe because the body is now consuming itself to stay alive. What organ are we trying to keep alive at all costs? The brain. The idea here is keep the brain alive. Okay, so I'm going to break down my GI tract. I'm going to break down my muscle. I'm going to break down everything just to keep my brain alive. I'll kind of put this into a little bit of a case study. Okay, so on the left, you're seeing a adolescent with kwashiorkor. Notice you have the pitting edema in the feet. Yes? Feet are swollen. The abdomen is the biggest place that you're going to see this distension. Okay. It looks like this child has eaten. Again, you know that is not true. Why? The extremities are from lack of protein consumption. Okay, so is this reversible? Absolutely. Okay, but we need protein, and the problem is protein is the most expensive macro out there. Think about your shopping. Okay. Now, patient on the right, this is going to be marasmus. This is pretty severe. This person here, unfortunately, there's a civil war in their country, and the opposing side blocked everything in and out of this village. So this village kind of starved. This is still happening today. North Korea is a great example. Okay, so looking at marasmus, do you guys see that patella? You can see every shape of that patella. Normally you have a fat pad underneath your heel to help absorb. That's just skin. This person literally has been consuming their body just to keep their brain alive. Okay, energy, non-existent. I'm going to tell you, standing, probably too painful. Okay, now World War II, concentration camps. British soldiers, when they liberated a concentration camp, this is what they found. People with severe wasting, this marasmus. British soldier wrote in their journal that they freed all of the prisoners, brought them outside in the sunlight, and started distributing rations. The British soldier described this one prisoner who had managed to finally open up the biscuit package, had this biscuit in their hand and just kept staring at it. This patient actually ended up falling over and dying a few minutes later. Why? Why didn't this person just eat said biscuit? You need saliva. What has happened to your salivary glands during marasmus? You broke them down. Okay, even if this person was able to eat this biscuit, all of that food goes into their GI tract. Do I have a GI tract left? Okay, water is going to get pulled out of my blood into the GI tract, causing heart attack, refeeding syndrome. This person was staring at the thing that could save them and understood if they ate that, they were going to die sooner. So, as nurses, how do we get around this? How do we feed somebody if they can't eat? IV feeding, and it's because of World War II that we developed IV feeding protocols. Now let's think about the 3 macros. You can do TPN as well if you wanted, but for the 3 macros, carbs, fats, proteins, for this person here who's severely wasting, which macro do you give first? If I give proteins, I need enzymes to build more proteins. Fats, if I give fats, again, I need enzymes to break it down, to circulate it. Carbs, why would I give carbs first? Sorry, say again.
Does it break down first?
It does break down first. In fact, we don't really need to break it down. I can just give somebody glucose. They can just straight absorb it. What organ have we been trying to keep alive? What does the brain only run on? There you go. If we get the brain's no longer freaking out, the brain's no longer eating the body. So now what can we give? Proteins. Now I can finally give proteins. So we can finally start rebuilding structures, rebuilding glands, rebuilding enzymes, rebuilding secretions. PN feeding for marasmus, you need to typically go in that order. Carbs, you don't need to write this down, but like carbs, you're looking at maybe a couple weeks on just glucose. We're trying to see how they're tolerating, and now we're going to move to just amino acids. Then we start moving to broken down lipids, give or take maybe a month later. Okay. Okay. So next part here, we're going to be getting to the liver. That's the end of the kind of serious tone here. So I'd say we're going to take a little break, but you guys already know the liver's a little daunting. So just heads up, this section is going to be a little beefy. Okay. You guys cool with 10-15, like 5, or we'll do 5 minutes, like 10-16 ish, but yeah, so 5-minute break. We'll pick up 10-16. Okay. Thanks guys for hanging in there. I know that was kind of dark. draft. Week 2 at the end of break, that's your actual schedule. Don't look at me, man. I'm in the same boat. They tell me where to show up and when. Like
When did you get it done?
during break, like actually week 11, I think, but it depends on placement and things like that. So some contracts have been finalized by then, some are still pending. So I think same rules, like you get a draft in week 11 and then finalize week 2 of break.
Start.
It can be as early as week 2. It can be as late as all the way to week 11. I've seen, so it's like, it depends. Because you usually do 2 days a week at clinicals. So it's 4 weeks. So it could be a month, could be in the beginning first month, could be at a month at the end. Ish. Yeah. Worst case scenario, typically with Peds and OB, because those are the hardest ones to schedule. They can't fit you into the quarter. They're going to send you for 8 days during break.
Like,
8 days, 12 hours apiece. Let's go. Again, worst case scenario. Yeah, worst case scenario, not likely to happen.
Oh, good, okay.
Okay, not likely to happen. I've only seen that as like emergency, red dawn, Russians are invading, like we need clinicals now kind of thing. Me? No, I bailed. I was supposed to do clinicals this quarter, but I ended up dropping out or withdrawing because between so much stuff going on in my personal life and classes this quarter, I just couldn't do med-surg 1. So I'm in the online class. I was supposed to do clinicals last quarter, or quarter before that, but I had the virtual option, and because I'm teaching, let's go virtual. So what?
the classes are
Farm and foundations. That's it.
and then clinical.
Don't say that, I don't ever say that.
I heard that you take med surg at the end of the quarter. Is that not true?
That is not true.
Okay, that's.
You take med-surg 1, quarter 3, med-surg 2, quarter 4. All right, so talking about the liver here, you guys know, hopefully your ears are perking up here. Liver, yes. So portal hypertension, high blood pressure. Actually, let me make sure I am, yeah, good. High blood pressure in that hepatic portal system. Hepatic portal system. Remember, the hepatic portal system is going to gather blood from all of those organs that just absorbed all your food and send it to the liver. Okay, these are different causes here. Intrahepatic. Intra means inside, and hepatic, what's the best filter of the body? Intrahepatic, inside liver blockage. So that means there's something blocking your liver that's inside your liver. That's going to cause blood to back up. Boom, you got hypertension. Okay, can be post-hepatic, i.e., where's the blockage? After the liver. Yeah. So that means it's between the liver and heart. Okay. Both of these things. So either way, we have some sort of blockage inside the after the liver, causing blood to back up. You got hypertension. Okay. So these are some potential consequences of hypertension. You got varices. Okay, let's think about this. Blood is backing up just like in your varicose veins, just like in an aneurysm, just like in a diverticulum. Blood's backing up, higher pressure. What's going to happen to your blood vessels? They're going to distend. Varices, distended veins. Distended veins at the hepatic portal system. So these are like varicose veins, but varicose veins in your legs. These are at your liver. Okay. Distended veins at the hepatic portal. 3 common places: lower esophagus, stomach, and rectum. You're also going to They say like label these consequences. Varices. Second one is splenomegaly. Splenomegaly. Nice. Why is your spleen getting enlarged? Kind of. So your liver is blocked. What does that tell you about liver functions?
Decrease your
Spleen is compensating for the poor liver. Splenomegaly, i.e. your spleen gets bigger to compensate for your liver. Okay. Ascites, talk about that. And then oh,
Oh, wow, yeah.
my bad. All right, cephal. When we are all cephalopods, that means basically we look like tiny shrimp. The cephal is the neural tube that contains your brain and your brain stem, okay, and your spinal cord. So cephal refers to brain and spinal cord. Pathy, does anybody remember what pathy means? Disease. So putting this all together, hepatic encephalopathy, disease of the liver leading to damage or disease in the brain and spinal cord, i.e. liver disease, oh god, liver disease causing brain damage. Liver disease causing brain damage. And we're going to walk through these consequences here. So first up, what we're seeing, these are varices. Okay. 3 places, your esophagus, your stomach, and your rectum. Think about distended veins in your rectum. What do we get to call those bad words? Hemorrhoids. Hemorrhoids can be a sign of a liver obstruction. Okay, it can be, it doesn't always have to be. But let's kind of use these as an example here. Somebody has hemorrhoids and they rupture. What kind of poo would you anticipate? You meant a cheese here. Okay. Esophageal varices rupture and a patient vomits, producing hematoemesis. Hemoptysis is bloody sputum. Okay, so would produce hematoemesis. Okay, patient has esophageal varices that rupture. What kind of poo would a nurse expect?
Yeah, how do you say it?
Melena, the dark tarry coffee ground stool. So you guys are all right. I was just waiting for the key term. Okay, so that's why I'm saying, like, use these as examples. Okay, know these terms. All right, big boy right here. This is ascites. Oh, Nelly. What's filling his abdomen? Fluid. That's a lot of fluid. Actually, let me back up here. Why? What's causing the ascites?
Increased pressure. I don't remember the term.
You're good. You're good. You're on the right track. What causes this edema? Portal hypertension. Kind of.
Capillary increased capillary. That's wrong.
I'm going to say decreased albumin. Okay. So portal hypertension leading to decreased albumin, that's your decrease in capillary oncotic pressure. What caused the portal hypertension? A blockage. So I'm going to say liver blockage. Now, what could be blocking your liver? Could be bile, could be a clot, could be a tumor. It's not a tumor, but it could be. Scar tissue could be another thing. Okay, so let's kind of roll with this here. This patient here has portal hypertension that leads to less albumin, ascites. What else could this lead to? We just talked about it. Happens in your esophagus, your stomach, or your blood. Varices. Okay. Other things that portal hypertension cause: hepatic encephalopathy. Okay. Other things that this can cause: splenomegaly. What else can liver blockages, liver dysfunction cause? What's your liver store? Bile, sure. I was thinking more like, we just talked about vitamin A. What happens if you don't have vitamin A? You could have night blindness. We could have jaundice. What about lack of vitamin D? Rickets, osteomalacia, osteoporosis. Vitamin E. Cancer. Vitamin K. Clotting. Vitamin B12. Pernicious anemia. Folate. It's an anemia with folate. Well, we don't store a lot of iron either, so iron deficiency anemia. It is folate deficiency anemia. Okay, I don't know about you guys, but verbally we just went over what, 12 different side effects of your liver going down?
Yeah.
Oh wow, look at that. I don't know. I keep trying to tell you guys that the liver is kind of important. So basically, if your liver goes down, what do you get to expect? Okay, one of those things: hepatic encephalopathy, impaired cognitive function, secondary to a dysfunctional liver. Okay, why? What happens is that your liver is going to convert ammonia. Okay, so heads up, this is ammonium ion. You can just write ammonia if you don't feel comfortable with that, that's fine. Huh? Oh, don't worry, I got you. So your liver converts, oh, I see the formatting.
Yeah.
Ammonia, it'll be just straight up ammonia. The reason why I'm doing ammonium ion is because the kidneys, you're gonna see that in lecture in that form. Sorry, now I got your question. We'll convert ammonia into urea. We'll convert ammonia into urea. Okay. Now, ammonia, this is something that you naturally produce. You make proteins, you break down proteins, ammonia is a byproduct. Ammonia is extremely basic. So if you're building ammonia in your body, what happens to your pH? It goes up because it's basic. Okay. In order to prevent this, your liver takes ammonia with another ammonium ion, slams it together and makes urea. Urea, thankfully, is neutral. Actually, let me kind of rewrite this or write this a little bit below. Ammonia, so it's N3, NH3, or NH4 plus. This is extremely basic. Urea is neutral. Problem is it's only temporary. Okay, when I have an ammonium ion and another ammonium ion, we slam it together, we make urea. It's neutral. So what does urea do to your body's pH? If it's neutral? It should do nothing. It should keep your pH as it is. Okay. Now, urea, you guys have probably heard of. What do we do with urea? We pee it out. Anybody have cats? Okay. If you have cats, they pee into a litter box, yes? When does the urine become absolutely rank? The day of or the day after? The day after. Same thing with this alleyway where all the hobos are. You can tell when somebody peed in the alley yesterday because urea comes out. Yes, stinks, but it's not bad. It's only temporary. After 24 hours, it disassociates and becomes ammonia. That's what you smell. So your liver, ammonia, urea, you pee it out, no problem. If it goes down, do I make urea? No. So if I have liver dysfunction, that's going to cause a decrease in urea. If I'm making less urea, what's building up in my blood? What's the problem with building up ammonia in my blood? Mhm. I will increase my pH. Now let's think about this. What organ is super sensitive to changes in pH? It's the thing that should be in charge of everything. This leads to impaired cognitive function, brain damage, because the blood is too basic. So, hey, your liver shuts down. Guess what? You get to look at brain damage too. Okay, not fun. Does that pathway kind of make sense there? Liver dysfunction, buildup of ammonia. So yeah, question on the exam might be something like, hey, patient has hepatic encephalopathy. What would be reflective of their pH? Anything above 7.45. Okay.
Can I ask them, all those pH levels, do they change depending on where you're, like, 7.35 to 4.5 is pretty normal, but then like CO2 levels and bicarb levels seem to like change based on what you're talking.
They have different reference ranges for different hospitals, different ages. It's just really kind of hospital's choice at that point. The textbook I learned it from, that was the ranges. Never really questioned it. But yeah, the CO2 and bicarb can be different. Okay, all right. Jaundice. You guys are very familiar with jaundice, right? A lack of bilirubin metabolism in the liver. Okay, i.e., we're not converting it into the bile, so bilirubin is building up. Obstructive jaundice, that comes from liver dysfunction. Liver dysfunction. All right, that means decrease in bile production, therefore increase in bilirubin. It could be your liver going down to cause jaundice. What other organ dysfunction can lead to jaundice? Spleen. Hemolytic jaundice, i.e. overactive spleen. Very good. Too much red blood cell breakdown leads to excess bilirubin. So either way, you have too much bilirubin. So let's run through some more symptoms here. Liver dysfunction, what is the possibility? What's a possible symptom of liver dysfunction? The hepatic encephalopathy, what else? That's the hepatic encephalopathy. Varices, esophageal varices, rectal varices, gastric varices, what else? Splenomegaly. What else? Decreased albumin leading to ascites, or that's another way to say ascites. Edema. What else? So vitamin A deficiency, vitamin D deficiency, vitamin E deficiency, vitamin K deficiency, vitamin B12 deficiency, folate deficiency, iron deficiency, anemia, all of those anemias. So that's like another 5. That was 20. You want to keep going?
Yeah.
What I'm getting at here is, again, remember how I said your liver is the central linchpin to this unit. It basically connects to almost everything. Okay. Hey, what's your stomach made out of? 3 layers of muscle. Muscle's made up of protein. Hey, guess who gives us the building blocks? Who gives us the protein? The liver through the hepatic portal system. Everything is practically tied to the liver. Okay. All right. Hepatitis. Okay, so hepatitis is a viral infection of the liver. You only need to know A, B, and C. Do not care about D, E, or G. Just A, B, C, good enough for me. Okay. Starting off with hepatitis A, usually transmitted via the fecal-oral route. Okay, so here in the US, not usually a problem, but sometimes it is. I don't know if anybody keeps up in the news, but last year with frozen produce, there was a huge hepatitis outbreak. Why? Unfortunately, the way the labor market is, I'm not making a comment on that one. But with the labor market, they're paid by the amount of fruit that they pick, not by the amount of time. It's faster to take a shift in the field and keep picking than to go off to the bathroom. Not commenting on the labor market, I'm just saying, hey, that's how poop can end up in your fruit. Okay, so fecal oral route. Is there a vaccine available? Yes. My dear God, I hope you have it. You kind of needed it to get here. Okay, so a vaccine is available. This is not likely to lead to chronic inflammation. Hepatitis A is not likely to lead to chronic inflammation. i.e., are you worried about getting hepatitis A? Oh, you got a vaccine for it. And even if you did get it, are you going to have lifelong complications?
No.
Not likely. Okay. So, big concern with Hep A? Not really. Hep B, hepatitis B, through somebody's blood, bodily fluids. I just think of B, blood. Hey, guess what? There's a vaccine. And it can cause hepatitis. Again, not likely. So, grand scheme of things, are you worried about hepatitis B? Not really. Hepatitis C. Okay. This one here, transmitted via blood. Okay. Vaccine available?
No.
Not yet. Working on it though. Vaccine is not available. 50 to 80% of Hep C cases result in chronic hepatitis. Again, you know, I'm never going to ask you about percentages, but 50 to 80%, i.e., if a person gets hepatitis C, are they looking at lifelong complications? More serious, yes? lifelong liver inflammation. And that inflammation can lead to things like what? Cirrhosis, sure. Blockages leading to varices. What else? Splenomegaly, absolutely. So yeah, we have problems, yes. So again, don't care about D, E, or G. All right, talking about liver cirrhosis. With liver cirrhosis, we have irreversible inflammatory disease that disrupts liver function and even structure, i.e., with liver cirrhosis, we have replaced more than 50% of hepatocytes with scar tissue. We have replaced more than 50% of our hepatocytes with scar tissue. How many functions does my liver have? About 200. How many functions does scar tissue have? Just one. Problem, yes? How did I have scar tissue in my liver? How do I accumulate scar tissue in my liver? Could be inflammation from damage, could be alcohol, could be fat, okay? So liver cirrhosis, actually kind of a pretty big deal here. Things become obstructed, can cause portal hypertension. Okay. Was. So a couple different types of cirrhosis. Alcoholic cirrhosis. Alcohol damages the hepatocytes. Now your liver is awesome. It can regenerate. So how is it that alcohol causes damage then? Well, this is excessive amounts of drinking repeatedly. Okay, if you constantly damage the liver, don't let it heal, it's going to get filled with scar tissue. As soon as we fill up more than 50%, that's liver cirrhosis. Okay. Biliary, I'm going to say don't worry about. Fatty liver disease, fat buildup can cause fibrosis and scarring. So this is also known as non-alcoholic liver cirrhosis, i.e. fat. If you take too much fat into your diet, your liver is going to store that fat. Adipocytes, fat stores. How many functions do they have? It's like one, store fat. Okay, so either we're filling the liver with scar tissue or we're filling the liver with fat. Both of those are going to cause the same kind of problems. Okay, most cases it's a combination of both. Just weird. So this is somebody's liver with cirrhosis. Again, it's filled with scar tissue. So can I go in there and just like start cutting out little nodules? Will that help? No, the scar tissue is all throughout the liver. Okay, we talked about some issues there. Let's relate this to material that will also be on this exam. How is this going to affect your blood? Yeah, but the hepatic encephalopathy, sorry, I should clarify. How does this affect the things in your blood, like your cells? Sure. So decreased filtration. What else? You'll have more because we're not taking out those. So we'll have increased dysfunctional red blood cells. Nice, nice. What does your liver secrete? Hormone wise, TPO. What do we use TPO for? Platelets. So I have less platelets. What's that going to happen? Or what's that going to cause? More bleeding. Yeah. Lack of hemostasis. What else does my liver do for my blood? Yeah, that's why we have increased dysfunctional red blood cells. We're not clearing it out as much. What else does your liver do for your blood? There's the intrinsic cascade, extrinsic cascade, classical common cascade. How's your liver interact there? Yes, it does make prothrombin from what? How else does it interact with those cascades?
It doesn't make the clotting, or the clotting factor.
Makes the clotting factors, absolutely. How else does your liver interact with your blood? It's at the end when you want to start breaking up a clot. Makes it breaks up fibrinogen into D dimers via plasmin. Decreased plasmin means, hey, you have now clots no dissolve. These right here all relate to impaired hemostasis. Same kind of symptom for different reasons. Impaired hemostasis. So, look at that. There was like another 6 that we just covered. Weird. Oh, sorry, too fast. So, hey, liver cirrhosis, why is this a bad idea?
Could you go over actions?
How? How am I going to die?
Painfully exploded. 200 different ways.
Yeah. Bleed out.
You could bleed out. You could have anemias. You could have brain disease. You could have an exploding spleen, splenomegaly. Hey, what happens? Okay. You're gonna have fatty poops that float. You're gonna go blind in the night. You might have osteoporosis. You might get cancer. You can't stop bleeding. And once you do finally make a clot, you can't get rid of it. So many more. Yes. All right. Now, gallbladder. Talking about the gallbladder. Be careful here. Latin is your friend. Read carefully. Cholecystitis versus cholelithiasis. You see how they're very similar. What's the difference?
One stone, one.
Itis refers to inflammation. So cholecystitis, that's inflammation of the gallbladder. Asis is the process. Cholelithiasis, that is gallstone formation. Okay, usually what ends up happening, cholelithiasis leads to cholecystitis. That's usually the kind of order of things. Okay, gallstones most commonly are made of cholesterol. Most commonly made of cholesterol. Why? Excessive bile salt recycling. Excessive bile salt recycling. You guys remember we secrete bile salts into our duodenum, reabsorb them at the ileum. Secrete them into the duodenum, reabsorb in the ileum. Every time we recycle these bile salts, cholesterol starts sticking to these bile salts.
So the living should be, just like these. A lot, like what's.
So kind of, remember we secrete cholesterol with it. Okay. Why does this happen? lack of fiber. You need fiber in your diet. Fiber binds to cholesterol and you poop it out. It also binds to your bile salts. So Honey Nut Cheerios, yes,
Yes.
their whole marketing campaign, Honey Nut Cheerios can lower your blood cholesterol. How?
It has fiber in it.
So I'm not gonna make you responsible for this. When you eat Honey Nut Cheerios, it binds to the bile salts. It binds to the cholesterol. You poop out the fiber. So now you have less bile salts, less cholesterol. You gotta make new bile salts. You gotta pull in new cholesterol. Where am I gonna pull that cholesterol from? My blood. I pull it in from my blood into my liver to make more bile. So by eating Honey Nut Cheerios, you gotta keep making new bile. That's what lowers your blood cholesterol. All right, pancreatitis. Inflammation of the pancreas. Sounds great. Not. Just like your spleen becoming enlarged, your pancreas becomes enlarged. If your pancreas ruptures, it's going to leak pancreatic enzymes into the tissue. What kind of enzymes does the pancreas have? It makes all of them. So what gets broken down if your pancreas ruptures?
Okay, well,
Your carbs,
well, technically all
your
of it.
fats,
All the stuff.
your proteins. This leads to auto-digestion. Auto, self, digestion, breakdown. Hey, your pancreas is dissolving you from the inside out. That's going to lead to necrosis. Skip the hypoxia, skip the ischemia, just straight up necrosis. Problem, yes? So, large spleen, large pancreas, don't poke it. Good. All right. Little piece of advice here. My recommendation, you need 3 things to live a fulfilling life. A, you need unconditional love, whether that be family, friends, pets, you need some sort of love in your life. 2, you need to have a career where you feel significant, where you feel like you've made a difference. I think that's why you guys are going into nursing. 3rd thing that you need, really good bowel movements. Think about it. The last time you had a poo, were you angry? Huh?
Well,
All right. I will see you guys Tuesday, but that'll be the cutoff for exam 4. Okay. Thanks for hanging in there, y'all. Hopefully this was entertaining.